Hey guys, it's Dr. Minardi here to bring you all things STEM. From my journey to yours, we are on an adventure together. And today we have the incredible opportunity to talk to Sohnee Ahmed. So let's welcome to the stage, Sohnee. Hey Sohnee, how's it going?
Good. How are you?
I'm doing well. And where are you joining us from?
So I am located in Toronto, Ontario, Canada.
That's exciting. So our show is now going international.
Yay!
Sohnee Ahmed is a board certified genetic counselor and variant analyst involved in genetic analysis and report writing for whole genome sequencing, whole exome sequencing, and panel tests. She graduated from the University of Toronto with an Honours Bachelor of Science specializing in genetics and biotechnology with a minor in anthropology. She then attended Wayne State University to achieve a Master's of Science degree in genetic counseling. Following her graduation, Sohnee was recruited to the University of Rochester in New York State, where she was a joint faculty member in the departments of neurology and medicine and provided in person genetic counseling to adults, parents, and families regarding cancer genetics alongside adult and pediatric neurology. While there, she established the first regional adult neurogenetics clinic, a child neurology neurogenetics consultation service, the first multidisciplinary heredity ataxia program in upstate New York, and she also helped develop Lynch syndrome, HNPCC, universal screening within the hospital system and community. That's amazing. She then returned home to Toronto and joined the Division of Clinical and Metabolic Genetics at the Hospital for Sick Children, specializing in pediatric neurogenetics and teaching and supervising master's students through the genetic counseling master's program at the University of Toronto. In 2016, she joined GeneDx and began working remotely, providing variant interpretations to healthcare providers that order genetic testing through GeneDx. Most recently, Sohnee shifted her focus to be between report writing on the neurology and clinical genomics teams and performing variant analysis for whole exome and whole genome sequencing cases. Sohnee was previously the president of the Canadian Association of Genetic Counselors and currently is an active member of the same association and its American counterpart, the National Society of Genetic Counselors. She also spends her time mentoring prospective and current genetic counseling students who identify as minorities in medicine. That is awesome. You are awesome. You are a powerful woman. I so appreciate you being on the podcast. And obviously, your bio speaks tremendously about your academic background, but tell us a little bit more about you as a person, Sohnee.
Well, first, thank you so much for having me. I'm excited to be here. And yeah, I mean, outside of that bio, I think the things that have kind of always guided me and have been sort of like goalposts for me have been pretty, I don't know, pretty straightforward, at least to me. One of the things that I learned really early on was it's sort of I don't know, kind of simplistic in some ways. People think about Mr. Rogers and how he would say, whenever you're in a situation, that can be a little bit scary, you always look for the helpers and look for those people that are helping others. And so the sort of guiding light for me that I had always was not only to look for the helpers, but if you can be that one of the helpers. So I've always wanted to find a way to help people in some capacity. And if there was a way to be able to combine that with things that I find interesting, then that was always that additional bonus. So coming across genetic counseling, that kind of merged a few of those worlds for me because I've always had an interest in STEM and an interest in science, specifically within genetics. And then finding that there was actually a career path within that lets you directly impact and help people. I mean, that just kind of really blew open the doors for me and wanted me to kind of go down that road a lot deeper.
No, I love that answer, and I can kind of mirror that answer exactly when I talk about my story because very few people think that a PhD in analytical chemistry can then go and make a difference in health. And that's exactly what I'm doing. And I think that characterizing yourself as a helper is so powerful. So let's start on your journey and let's discuss your love of science. I mean, you talked a little bit about the genetics piece, biomolecular, molecular, cellular. Um, what was it that really drew you to that?
I mean, as a kid, the concept of how things work and why the world is the way it is has always just been interesting for me, and being able to ask those questions and then find out that a lot of people before me asked those same questions and we're finding out some really cool answers. And in particular within genetics, that seemed to be the space where we had far more questions than answers. And certainly at the time when I was first studying it, there were way more questions. We still have a lot of questions about genetics, and it probably is one of the younger fields of medicine, of science. So there's a lot of room to learn. And I find that I am learning new things all the time. And even within the realm of clinical testing, which is outside, it's separate from research testing, where you might be doing a lot more gene discovery. Even within a clinical space, there's still a lot to learn, because there are a lot of conditions out there, and there are a lot of people who have those questions of what's going on with me, what's going on with my family, and that's always been really interesting to try to figure out. And so, being a genetic counselor, a part of what you do is helping guide people through that journey of figuring out what's been happening, what's that story in your family, what's the underlying explanation, helping guide them. And then also on the molecular side of things, trying to actually dig through that and figure it out, look at that raw data and see what comes out of it, what's salient and what makes sense.
So I remember on our one of our first conversation, we talked a little bit about um, causation, correlation. How do you actually tweeze those two apart, especially for genetics? Because if you think about it, there's the actual molecular sequencing and the genetic sequencing, and then it correlates or it causes direct, like phenotypic uh, correlations or causations or reactions.
Mhm.
Um, and I think that is really, as technology gains more momentum and evolves, the ability to really tweeze those two apart, I think is key. And that's why it's such a new and novel field, is because it's constantly evolving.
Absolutely. I mean, we're finding out more and more about individual genes themselves, and to what extent they're multifactorial. If they have environmental impacts or any kind of threshold that needs to be crossed before a phenotype presents itself. Does it have reduced penetrance, or does it have variable expressivity? I mean, there are so many variables there. There are so many aspects to be able to determine if something is truly causative and is the explanation or not. So it's not always this very direct sort of genotype phenotype correlation, but you do have to be asking those other questions as well. And that certainly poses quite a challenge as we go through genetic testing. So sometimes, depending on the case, it can be really straightforward, and you find an answer and you go, yep, absolutely, this is 100% genetic. Here's your answer. This is what it is. And then other times it might not be as straightforward.
Well, and I think that's where the position title or the profession really comes into play, with the actual words of saying a genetic counselor, because I think the counseling part is not just limited to explicitly describing what is happening at a genetic level, but also that it taking all of those comorbidity factors, social behavioral status, all of those other sort of factors into play from an environmental standpoint, so on and so forth. And then how are they actually interplaying to then get to the results that you're seeing from a patient?
Right. Yeah, the counseling component is kind of both educational as well as the emotional component. And so we do provide a lot of education to patients, explaining what the testing we're either considering doing or have already done, sort of what is it looking at, what did it look at, what are the potential results if we haven't done the testing yet, or going through results if we already have, but then also discussing all of the emotions around that, because what you're doing essentially is potentially changing a person's life, and even how they might identify themselves, and what that means for themselves, what it means for their family, for their place within their family, how they see themselves within their community. There are just a lot of facets there that also can be explored, and that a genetic counselor is well equipped to be able to do.
So you were at the University of Rochester as a faculty member,
Mhm.
and I want to just kind of poke at that a little bit of asking curiosity questions around, what was it like in a day in the life of? Because you were not only a faculty member, which then obviously correlates to teaching and mentorship, but you were also a practicing clinician.
Mhm.
And so, talk a little bit to the audience about a day in the life of and why did you actually transition to your next role?
Yeah. So traditionally, genetic counselors they started out in a prenatal field. When the profession first was created, it was predominantly to see pregnant people and discuss what could be happening within their pregnancy, if they saw any differences within ultrasounds, and offering genetic testing. Then, as we improved our technology, we started to expand the roles for genetic counselors. And we were in other clinics, we were in hospital systems, outside of hospital systems, and now we're in multiple areas across healthcare. But going back to that traditional space, in a lot of the training programs, we're basically taught how to be clinicians and how to be within a clinical space and see patients. And so, with that being my training, I had the thought of, okay, well, then as soon as I graduate, I want to be in clinic. And that's where I'm going to be able to hone my skills. And that's where I'm going to be able to study for my board exams, because a lot of the questions are going to be clinically based. And I can see patients and make that direct impact and be able to be that helper that I was alluding to before. So when I was there at the University of Rochester and I was split between those two faculties, my days were literally split. And so there'd be some days that I'm in a clinic for neurology, and then there'd be other days that I'm in a clinic under the Faculty of Medicine, which would be seeing patients in the cancer clinic. So those would be predominantly adults, or seeing pediatric cases. So that would be children and families, and really for any indication. But the more common indications are things like autism, developmental delay. My subspecialties involve movement disorders and brain malformations as well. But I would see children for a lot of different reasons for them to come and see genetics. So most of my time would be spent within clinics, seeing patients. And outside of the clinic, it would be doing a lot of case prep. So when we get the referrals initially saying you're going to be seeing this patient, I would go through their records, collect all of the necessary information and whatever is already provided up front to be able to start putting together a picture of what kind of testing we might be considering, and sort of what kind of game plan we might have going into the room when we actually have our appointment. The appointments themselves are usually about an hour long, especially if it's the first time we're seeing a patient, which is pretty different from usually when you go see a doctor and you've got like 10 minutes. We do spend a lot of time with them because we go through their full medical history. We go through a full family history of 3 generations. And then we go through some time of really discussing, like, why did we get all that information? What are we taking from that? What salient points are helping us to guide us towards a diagnosis? And then what sort of genetic testing might be indicative? And then we also talk about the fact that there's consent at every point as well, that genetic counseling and genetic testing isn't for everyone, and that they might be referred to come see us, but that doesn't mean they have to move forward with anything about it. There's a lot of things to consider when pursuing genetic testing. Not just do you want to know the answer, but also what are the implications of having genetic testing with regards to getting life insurance? And, does this change anything about employability or health insurance? So we go through all of that information and have an open and honest discussion with the person in front of us before we really move forward. And when I was in the US, there's also that fun component of health insurance and seeing if the genetic testing would actually be covered or not. And if it wasn't, how much would be out of pocket, and having that kind of financial discussion as well before moving forward with anything. And then later on, we could have a follow-up appointment, a few weeks or a month or so down the road to discuss results if they did end up pursuing testing, and then discussing what next steps might be. So that was sort of how my days were structured, as either doing the prep in advance, seeing the patients, or doing some of the work afterwards. And that could be going through test results, preparing for follow-up appointments, writing letters, be it letters of medical necessity for insurance companies, or just follow-up letters afterwards that go back to the referring physicians to discuss what we had covered during our sessions. And then there's teaching in between all of that.
No, thank you. Thank you for that. I'm curious. Question popped into my mind because, when a patient gets genetic testing, they are at the point at which, or they receive the testing that is not only most appropriate for them, that the genetic counselor and them talk through, and consent, which I think is so important. But there's also a point of, as the field evolves and as genetics testing evolves to broadening different tests, how do you think about patients who then come back, or how do you do like a feedback follow-up mechanism as, hey, we have this new genetic test that may be appropriate for you? What does that actually look like?
That's a great question. I think each hospital system kind of has asked that question, and they might have a slightly different approach to it. But generally, we do like to keep that door open, because absolutely, testing has evolved. Even within 5 years, things can change. And so the test that we may have offered 5 years ago that came back with no answer, that came back completely negative, we usually say in our letters back saying, this testing was negative. However, should additional testing come up, please come back and contact us. Also, if additional features arise, and this was more prevalent within the pediatric setting, because as children grow, we might start seeing other things come up. And so if there are new symptoms that appear, come back, because we could do a reevaluation. There might be additional testing to consider. As technology itself improves, a negative test could end up becoming a positive test later if there's additional methods that are utilized that weren't previously available. And so I'm thinking back to how we used to do single gene testing for particular conditions. And now that's essentially a thing of the past, and we're going straight to whole exome now. And we're looking at essentially every gene to be able to find that answer. And that's something that we couldn't have offered a few years ago.
No, thank you for that. I think keeping the door open for patients to come back, but then also, providing public awareness for what is the newest up to date testing is always, I liken it horrifically, but I liken it to sort of the COVID outbreak and talking through communications, of things were changing every hour on the hour. And so the communications were always changing. And so how do you actually be that voice of reason to the patients, to say, yeah, you probably should need this, or come back and then maybe there is a new test.
Mhm.
Um, so in 2016, you transitioned from academia, health system, clinical care to GeneDx. So tell us a little bit about the why and what your role was.
Yeah. It was definitely a big decision to make. I think a lot of genetic counselors, especially when we're first going through our training, we're taught within clinical settings. And it's not as common to be shown other positions and other places that genetic counseling can be. That is changing now. So I know that there are programs now that are expanding and being able to provide those other perspectives for genetic counselors. But at the time that I was in school, that wasn't an opportunity. But personally, the reason that I had actually switched was, it was actually more so for personal reasons than it was for anything career or professional. And the fact was, I was on a contract when I was at the hospital. And it was a renewable contract, but it was still a contract. And I needed something permanent. I wanted to move forward with my life. I wanted to get married and have children and buy a house and, do all those things that isn't as sustainable if you don't know where your next paycheck's going to come from, right? So when the posting went out and it was a full-time permanent position and it was completely remote by design, I started to kind of put it together and think, okay, so I'm going to be shifting what I'm going to be doing, but I'm not going to have a commute and I'm still going to be in genetics. I'm not going to have that patient interaction anymore, but I'm still going to have patient impact. So maybe this could still work out. So instead of using a lot of my counseling skills that I had been previously using in clinic, I was using more of my molecular background. And so it did kind of force me to brush off those skills a little bit more and start looking back in some of my old textbooks from undergrad as well, just to remind me of mechanisms and things, and to reacquaint myself with the American College of Medical Genetics, the ACMG criteria on variant classification. But it was a really great challenge, and I wanted to just kind of dive right into it, and thankfully was given the opportunity to do so. And I've really been enjoying it ever since. So it has been nice, especially after when the pandemic hit and everyone had to go remote. I was already set up for that. So that made things really easy to be able to continue in the stream that I was going in without having to have a lot of major disruptions. Um, and uh, and I've still been within that realm of genetic counseling, and I still interact with other colleagues who are still in clinic because I'm just kind of on the other side of it. And so I used to be the person who would order the tests and then present the results to the patient. And now I'm on the other side of receiving that test request and then creating that report that goes back to the person who ordered the test.
So you made a jump as a clinician from clinical care to industry for
Mm-hmm.
very, very broad descriptors. Um, and some people find that really challenging. It's a different sort of look and feel, it's a different environment. You have to be a little bit different. You have different priorities sometimes. So can you talk a little bit about how did you go through that evolution and how did you manage that change?
Yeah, there was definitely a bit of a learning curve there, coming from a place that is almost entirely academic, and then now having to shift into more of a business mindset. Now, being in clinic, a hospital system is in and of itself still a business, but that's not necessarily how you think of it up front. I mean, there are overhead costs when you're in a hospital. You are billing for services. There is still a financial component to it, but it does feel different when you're on the other side of it and you're now billing per test and there are quotas to meet and benchmarks. So it is certainly a different approach to things, but the bottom line of still thinking about each patient and each report that comes through and each case being an individual person that you're helping, that has not changed at all. So having that be sort of the core to what I do every day, having that be consistent, I think has been sort of a nice anchor as other things within the day-to-day do end up shifting.
Yeah, and you're still being that helper just in a different facet, right?
Exactly. Yeah.
Um, so we talked a little bit about single variant analysis, shifting to exome, whole exome analysis, and I want to give you the opportunity to talk a little bit more about, where do you think the direction of the field is going? Can you describe how you, as a person in a profession that has been changing, has, I think, maneuvered through that evolution in your career um, yeah, and just talk to the audience a little bit about that.
Yeah. I mean, I think when you have a certain mindset and you learn things in a certain way, and then later, a few years later, suddenly you're told, nope, all that has to change. It can be a little bit scary to have things shift so much, but it's also really exciting. And I think it's really cool that we're going in a different direction and that we're able to be more personalized with our approaches and with our processes. The way I think about it is it used to be you would, have a test, you have an answer, and then you kind of go back and go, okay, so what about this particular answer fits my patient? And now it's sort of flipped itself on its head, where now it's phenotype driven testing. And so we're asking the clinicians, tell us everything that's happening with this patient. Go through all the stuff that they have. And then we're going to do full sequencing and then pull out what's relevant from that. as opposed to you just ordering a panel for one particular symptom. So the example that I think of a lot is like epilepsy, for example. A child comes in with seizures and they order an epilepsy panel. That is a set number of genes that are associated with epilepsy. We might find an answer and then say, okay, yep, if their seizures are caused by a change in this particular gene, this could impact the medications that you're going to prescribe. This is what you're going to do down the road. But if that test was negative, that doesn't mean the person doesn't have a genetic form of epilepsy. It could just mean that the gene it's associated with just wasn't on that panel. And then that's when you can do exome. And there might be a gene that says, yeah, no, this is what it is because this particular variation is damaging to the whole protein, completely shuts it down. It's whatever the mechanism might be. And it's not just seizures. So then it also tells us what else we can expect down the road and can also potentially explain other features that may not have been that primary indication. Because yes, this child has seizures, but they also have developmental delay. They also have tremors. They also have breathing difficulties, whatever it might be, could also be explained by changes in this other gene that wasn't originally considered. So it's been that sort of paradigm shift of like, how do we approach the testing? That has been kind of this interesting shift. And then that's sort of where we're at now. And then the next step that I'm seeing sort of down the road, because a lot of people who are completely healthy have also been pursuing whole exome and whole genome sequencing. That's pretty different too, because we're not looking for anything in particular, saying you have these particular symptoms that can be explained by this particular set of genes. So we could also be doing full sequencing for people where we don't have an indication. And then we're going to be pulling anything and everything that's relevant and presenting that, and either holding a lot of that data and presenting it as symptoms arise, or presenting it all at once and say, hey, this is what could be coming up down the road. And a part of that is being done now because when you opt into pursuing whole exome and whole genome sequencing, you also have the option to opt in or opt out of secondary findings. And secondary findings are basically variations, usually pathogenic variations in genes that do not necessarily imply you have a disease at this time, but could be something that happens down the road. And certainly if you're doing whole exome or genome sequencing and you're not the only one providing a sample, but let's say it's child and both parents, we could be getting information about parents as well. And a common example that we would give is BRCA1 and 2. So, everyone knows from Angelina Jolie and from other celebrities who had this testing known as the sort of the breast cancer genes. It's associated with many other cancers as well. So there's breast, ovarian, melanoma, prostate and pancreatic cancer in particular. And a child might be going in for whole exome sequencing, again, for seizures, for example, and then they've opted in for secondary findings. We can also say, this child also has a pathogenic mutation in BRCA1 that was inherited from the father. Dad might not have cancer, but now is told they have an increased risk for it and should consider screening. So it can have medical management implications now or potentially down the road as well. And I think that that's opened up a lot of discussion of, sort of where this can go in the future, especially, again, if someone who's completely healthy is ordering this testing, they could just be asking for essentially secondary or incidental findings sort of throughout their genome.
No, the secondary findings is interesting. The medical management is interesting. I really loved, and I wrote my NSF fellowship on single cell analysis for personalized medicine because I love the idea of having and using genomics, proteomics, all of the different omicses, if you will, in talking about pharmacogenomics. And when you talk about treatment regimes, you said medical management, that's spot on, but also not every person is equipped to fully combat like chemotherapy, as an example, when a cancer strikes, unfortunately. And so how do you think about that? And what is the preferential chemotherapy regimen? And so there's almost an advisement piece too, to, I think it's interesting to me because genetics has really evolved from a point of, okay, your genetics now state that you may get this. There is a probability to it. But that it also has evolved to, how do you treat it? What is the most effective treatment? What other secondary findings are there? I mean, it has broadened its use case to such a great extent.
Absolutely. I mean, what we used to say, but even like certainly before a lot of the treatments we have now was, well, if you have a diagnosis and there's no treatment for it, you might be eligible for clinical trials. And that is still the case for a lot of rare conditions. But now we're also able to say more and more. And now you're also eligible for this very specific treatment because you have this particular mutation in this particular gene, because things are becoming so personalized, even within the realm of orphan conditions, which are basically very, very rare conditions that traditionally pharmaceutical companies didn't really go towards because they're not going to be able to make as much money because they're not going to have as many affected people who need the medication. But that's shifting now too. And the fact that everyone's genome can dictate not only what conditions or what features to expect, but it also dictates what medications are better for them and what dosage. I mean, you mentioned pharmacogenomics. A big part of it is also what kind of metabolizer are you? Would you benefit on a low dose of something, or do you need something stronger in order to get that same kind of impact? I mean, that's kind of testing would be really helpful, I think, for a lot of people before they're prescribed particular medications. So that way they don't have to try a dose and see what happens. They can just know up front what kind of metabolizer they are.
And I'd be curious about your thoughts around gene therapy, because I think there's a question, the recent Nobel prize winners in CRISPR-Cas9, and altering genetic sequencing so that is then ameliorated. It's, do you manage the medical impacts and effects on the back end, or do you actually stop them in the beginning from actually, doing gene therapy?
Right. I mean, ideally, you want to be able to approach a condition before any symptoms start, right? Especially, I'm thinking about, neurodegenerative conditions, Alzheimer's, Huntington's disease. The research that's been done has always been looking for, what are the precursors? What are the clues that we get before symptoms start? How do we stop this in its tracks? And I think certainly gene therapy can be one of those arms of research, and one of the approaches that can be taken for a lot of conditions, where if you know up front that they're going to be getting this condition down the road, why not do something to be able to stop it? And again, especially for things like neurodegenerative conditions that are just so debilitating, and they impact the individual, they impact the family. It's this ripple effect. I mean, there are a lot of family support groups and organizations that have had that approach with regards to just genetic testing. Of, if you know in advance, then you can make choices about even, when you choose to have children, if you choose to have children, what you'd like to do with your career, and like how you change your life, knowing that information up front, whether or not you have symptoms, whether or not you've actually been diagnosed with a condition. Just having that information can be so powerful. And certainly knowing that gene therapy is potentially an option, I think will also really empower a lot of people as well.
Yeah, patient empowerment, and you're actually giving patients the right to then say, yes, I want to pursue this treatment, or I want to go a different route,
Mhm.
and giving them the optionality around it instead of just dictating what they're going to do. I think that's
Exactly.
huge. Um, One question I do have is around bioethics. How was that incorporated, and is that incorporated, in constant training with your career? Because I could just assume that it would be a huge portion of it.
Absolutely, it is. It is something that's brought up from day one. So genetic counseling, I mentioned, like it started in the prenatal setting. Really, the history of genetic counseling is steeped in some pretty ugly truths. and some pretty horrible history, thinking about eugenics. And a lot of the original people who kind of founded the concepts of genetic counseling were very pro eugenic. They were a part of the Nazi movement, they were a part of other eugenic movements as well. So, knowing that that is the history of the profession, trying to stay away from that, but still recognizing that that's its roots, the ethics within there will always be a very huge portion of training as well as what we do on a regular basis. I mean, when you're in a prenatal setting and you're telling a person who's expecting a baby, this baby is expected to be born with this genetic condition. A part of that counseling is discussing, what do you want to do with that pregnancy? Are you going to continue it or not? And that's a huge ethical discussion in and of itself within that microcosm. And it says a lot about the profession as well, because there's that discussion of, how do we view people with disabilities, and how do we view people who are differently abled in any way, be it intellectually or physically or otherwise. By offering genetic testing, are we implying anything about their existence and whether or not they should exist? And I think that as we're moving forward, we're keeping that lens there and making sure that we're not shying away from that, and also being very clear on the fact that we do support people with disabilities, and that being differently abled is just a part of the spectrum of humanity, and it's meant to be there. The questions about why do we offer genetic testing and what do we do with that information is such a personal decision. And ethics itself is also very personal, but it also impacts a global population as well. And how do we approach that and treat that is something that we do discuss on a regular basis and talk about, because it's not something to be ever taken lightly. And it's something that we do discuss with patients on a regular basis, and how we think about approaching genetic testing too. Yeah, it's always on the forefront, and even thinking about it from a different, slightly different perspective. Who wants genetic testing, and who gets the genetic testing, and what the results can mean? I mean, a lot of that also comes down to what their background is, and there's a lot of bias involved in that as well. And being aware of that, conscientious of that, and then looking at ways to be able to alter that, I think, is an important discussion that needs to be had, and is happening within the field of genetics, and I think will continue to happen as well.
No, it's a challenging topic, and I think, again, providing optionality to patients around, what do you want to do, and here are your options, and you self-select, and this is the wisdom and guidance that we can give. That's a huge part of the counseling aspect, right? Um, so, Sony, this conversation has been wonderful. I have one last question, which I tend to ask all of my guests. But if you were to roll back time 10, 15 years ago, what wisdom would you have imparted on your younger self? So, knowing your career has gone the direction that it has.
Well, I think something that was probably different for me compared to, I think, a lot of my colleagues, and classmates, even in undergrad, is that a lot of my stuff kind of looks linear on my resume. That I was in genetics from undergrad, and I'm in genetics now. And a lot of people don't necessarily follow that straight linear path. So I would probably tell myself, as well as others who were there with me at the time, that if you ever wanted to deviate from what you think your final destination is, that's okay. And it might not be exactly what you picture it to be, but that could be because what you end up being hasn't existed. It doesn't exist yet. And so a lot of career paths that people are thinking about now, it's okay if you don't have the full picture fleshed out yet, because the job might not exist yet. And that was certainly the case for me. I mean, again, it was linear for me. I'm in genetics, but when I was first in genetics in undergrad, I never thought that I would be in industry and doing variant interpretation because that wasn't a thing when I was first in undergrad. I mean, by the time I was in my third year, that's when I first even discovered what genetic counseling was. And I did a quick little pivot and figured out, do I have all my prereqs to be able to get into my master's programs? Um, so wherever you are in whatever stage of career you're at, if you're thinking, I think I want to try something different, but I'm not entirely sure what job this is. I just know I like these components. There's probably a job out there yet that you just don't know about that combines those components. So just kind of keep your eyes and ears open because it's probably out there and you're just not sure about it yet.
Or it may not even be a thing. And you just have to kind of wait it out, unfortunately, and build up that skill set so that when it becomes a thing, then you're like, I'm first in line.
Exactly.
Well, Sohnee, this has been, again, a wonderful conversation and a whirlwind conversation, not only from, historical perspective of genetics to genetic counseling, bioethics of this. I mean, we essentially did a tour de force, I think, in the last 40 minutes. But it has been a pleasure. And we are so honored to have you on the podcast. So thank you again for your time and for your engagement and for being a helper to our genetic counseling sort of environment and contributor.
Well, thank you so much. It's really been an honor.
Thank you. Bye, everyone. At STEM From, we are working towards making all STEM careers achievable regardless of your identity, background, or even access to resources. Here at STEM From, we will introduce you to all things STEM, whether they be careers, research, tips and tricks, and even inspiration. Thanks all for watching and learning with us today. Don't ever forget to ask yourselves, where do you want your journey to stem from? Thanks, everyone.